Thank you, Dr. Lim. I shall now call on Dr. Paz-Arcilla to start her rebuttal.
Breast conserving surgery is mainly, the main advantage is cosmetic. If the cosmetic side, if cosmesis is the problem, immediate reconstruction following MRM can be done. This can be used by using flaps or implants, as advocated by several studies abroad. As regards early detection, breast conserving surgery encouraging early detection, I would think that self-awareness or encouraging patients to do self-examination would promote earlier detection of breast cancers. Regarding survival rates have indeed been shown to be similar, but recurrence rates as shown by more recent studies have shown that local regional recurrence are higher in patients undergoing breast conserving surgery. As I have cited, patients have as high as 2 to 21% local regional recurrence rates for those undergoing post-operative radiotherapy, and as high as 33% for those not undergoing post-operative radiotherapy. As regards the applicability of breast conserving surgery for all histologic types, this has been shown to be not true, as extensive intraductal component and lobular invasive carcinoma have been shown to have a higher risk for local regional recurrence. And as regards to the public demand for better service, if the facilities are available, and this is not so in all areas of the Philippines, then MRM would be the best, would provide the best service for our patients.
Thank you, Dr. Paz-Arcilla. I shall now call on Dr. Lim to start her rebuttal. Dr. Lim.
I'd like to answer that when you mentioned local recurrence rates, there are voluminous materials already at present which have proved that MRM and breast conservation have practically the same local recurrence rates. And why we want to do breast conservation is because we want to give the patient options other than this very mutilating surgery. And there are several studies to prove that even with stage 1 and stage 2, even without axillary node, with or without axillary node dissection, even without radiotherapy, the results are very good. And about your comment about recurrences, Lagios in the Surgical Oncology Journal in May and June of 1992 stated that the number of pathologic factors appear to affect only local recurrence. These include the positive margins, gross multicentricity, extensive intraductal carcinoma, and invasive lobular carcinoma. They all share a common feature of a greater likelihood of local residual tumor burden. That is why for these patients we recommend doing radiotherapy. And you also mentioned that the histologic type is not doesn't go for all histologic types. In a study done by Waite and published in the International Journal of Radiology and Oncology in 1992, wherein they studied 879 patients with stage 1 and 2 breast cancer underwent excisional biopsy, axillary dissection, and radiation with a mean follow-up of 61 months. They found out that the histologic subtype of invasive breast cancer is not an independent risk factor in predicting survival or pattern of failure. Conservative surgery and radiation therapy is effective treatment of ductal, lobular, medullary, colloid, and tubular invasive breast cancer. We are not trying to do this for all patients. We want to have options for selected patients. Since our primary goal is to have a life functional and satisfied patient, we are not going to present an option to them which could endanger their lives.
Thank you, Dr. Lim.